So benefits of fecal microbiota transplantation, you can get rid of C. difficile infection about 90% of the times, roughly with one or more treatments. And when you think about the true efficacy of FMT, when you look at clinical trials, it may be slightly lower than what you see in case series. There are some disadvantages of fecal transplantation, which include the heterogeneity of the practice, the heterogeneity of donor stool screening, and we've seen some adverse events, including ESBL, E. coli transmission. One patient died after fecal transplant, some sugar toxin producing E. coli. So there's lots of disadvantages of fecal microbiota transplantation in that situation. Compared to other therapies, so I wouldn't call them synthetic because a lot of them are still stool derived. So we call them as standardized microbiome-based therapies, not synthetic, because they're not completely manufactured in the lab. They still are dependent on donor stool. Those are currently in clinical trials. There's very small availability, almost close to none in terms of outside of clinical trials. There is an assured active treatment program that Ferring and Rebiotics runs that you can use that treatment for outside of the clinical trials. Other than that, when we look at the data that's come out from these studies, there is no safety signal that's seen. And so the big advantage, of course, for enema and capsule-based therapies is the fact that these are non-invasive. They don't need a bowel prep like a colonoscopy does. The enema doesn't. The capsules, they still want to do a bowel prep. There's no sedation, there is no anesthesia, there is no procedure, there's no recovery time from procedure. So all of these are benefits from these capsule and enema-based therapies that we're looking forward. Hopefully, one or more of these will get FDA approval in the near future. Good question. So the majority of the studies are done in people with 3 or more episodes. RBX 2660, which is the enema-based therapy, also includes people with 2 or more episodes. So it's kind of a little bit earlier in the cycle of recurrence. And when you start looking at people with 1 or more episode, that one is a true synthetic. So VE303 is a true synthetic standardized microbiome-based therapy, is not donor-derived. And that clinical trial, we don't have all the results from that quite as yet, but a phase 2 study, they did include people with first infection. You're right, patients are asking for this. Patients are like, I've had it 2 times. Why do you want me to wait for the 3rd time for it to come back? And I think that's where some of the studies have included people with earlier on in the C. diff journey, specifically RBX 2660, I think is the largest program that has done that. And hopefully we'll see what the FDA and other governing bodies say when it comes to approval. And hopefully we'll be able to use this earlier in the disease course.